I will introduce tonight's lecture. So tonight's lecture is Improving Neurodivergent Wellbeing, Novel Findings from Clinical Research by Dr. Lisa Quadt. Dr. Quadt is a neurodivergent researcher in the Department of Clinical Neuroscience and the Brighton and Sussex Medical School. Her research focuses on brain-body interactions in neurodivergent adults and how we can improve their lives through tailored and novel support strategies. Please note that tonight's lecture does contain discussion of topics that may be affecting to some of our attendees. We believe that discussion of these topics is important to aid our understanding of health disparities. Lovely. So with that, I will hand over to Dr. Quadt.
Thank you very much for the introduction. Thanks everyone for joining tonight. I will just share my screen real quick. Okay, so Zach already told you, my name is Lisa. I am neurodivergent myself. I'm autistic and have ADHD, and that is also what I do my research on, which I will talk with you about tonight. Okay, so tonight I will talk with you about a bunch of things. First, I will talk with you about what is and isn't neurodivergence and neurodiversity. Then I will give you a bit of insight into neurodivergent well-being, or rather neurodivergent unwell-being, because unfortunately often it is quite low. Then I will talk about some of our research about loneliness in autistic adults. And then we will talk about neurodivergence from the neck down and what joints have to do with it. I hope it makes sense when I talk about it. And then I will give you some take-home messages. Just a disclaimer, Zach already said it as well, but I will talk about difficult topics, including mental health difficulties, suicide, self-harm, loneliness, and medical neglect. So please take good care of yourselves. Do feel free to leave, take a break, watch with a trusted person. If you do not feel well, you can come back to the recording if you wish. So there's absolutely no need to stay if you think that might not be good for you. Okay, I will get started with what is and isn't neurodivergence. And the first thing I would like to know is, what do you think of when you hear neurodiversity or neurodivergence? I will give you about 15 seconds, or maybe a bit longer, depending on how many responses I get, how quickly. And then we'll have a look at what you all think. All right, let's see what responses we have, and more are coming in. Thinking outside the box, I like that one. Autism, the brain's function, ADHD, a spectrum of differences, that's a good one. Difficulties with learning. Okay, so I see you seem to already know quite a lot about it, which is great. And up here, if you can see this, brain is coming up a lot, different is coming up a lot. So yeah, keep answering. I'm really always curious to see what people come up with. And I'm glad you mentioned autism, ADHD, and dyslexia, because I will be focusing on autism today. We'll also talk a bit about ADHD. But dyslexia, dyspraxia, dyscalculia are also neurodivergent conditions, but I will not focus on those today. Okay, so there are two terms that are important when we talk about neurodivergence. And to be honest, it took me a probably embarrassingly long time to understand what the difference between them is. But basically, neurodiversity refers to the fact that there are many different types of brains, right? If we are in a virtual room like this one, there will be, let's say, autistic people, non-autistic people, dyslexic people. And so we are a neurodiverse group because our brains are different. We have different brain types. When we talk about neurodivergence, we talk about when an individual has a brain that is different from what we assume to be the majority of brains to be. So a brain that diverges or differs from other brains. So me as an autistic person, I am a neurodivergent person. So there is a difference between neurodiversity and neurodivergence. A group can be neurodiverse, an individual is neurodivergent. And then something that, I gave a a talk to a group of people that was probably 2 generations older than you all are. And they kept asking me, don't all these kids want to be neurodivergent these days? And, you know, everyone wants to have ADHD and it's such a trend, and everyone wants to have autism, which I don't believe is true. I think we are just much better at picking it up these days. But if we look at the official numbers, it's actually unclear how many people are neurodivergent. The official numbers say 2% of the population are autistic, 8% have ADHD. It is likely much higher than that because of the way how we diagnose people. The diagnostic criteria we use are based on research that was mostly done in little boys. And we know that not everyone who is autistic or who has ADHD necessarily behaves exactly like the diagnostic criteria tell us they should to get a diagnosis. There's one estimation by an organization called Embracing Complexity that says approximately 10% of the population are neurodivergent. We have some unpublished data where we find if we give 300 people screening tools for autism, and they're just the general population, about 25% meet criteria. But this is only a screening tool, it's not a diagnosis. So that's also important to keep in mind. Then we have to know that individuals from any group, any culture can be neurodivergent, and that they differ in all aspects of human characteristics. They're not all the same, just like non-neurodivergent people are not all the same. And some professions may select neurodivergent individuals. So that means that for some professions, for example, medicine, it might be especially good to have neurodivergent traits, such as very, very intense interests, the ability to hyper-focus over hours on one topic, having an attention to detail, being creative, and having a very strong sense of justice. So it might just be that in some professions, we find more neurodivergent people than in others, whether these people know that they're neurodivergent or not. There are 2 ways that we now think of neurodiversity and neurodivergence. The traditional model is the medical model, and then recently, over the past 2 or 3 decades, the neurodiversity model has emerged. And I will quickly tell you what the difference between these models is. So traditionally, we saw autism, ADHD, and probably many people still do for their own reasons. We saw these conditions as inherently deficient. So this is the DSM-5, which is the diagnostic manual that we use to diagnose people with different conditions. And when you look at the language here, all the things that I have underlined or put in a different color, these are all quite negative words, right? We talk a lot about deficits, abnormal social approach, failures, again, deficits, restriction, repetitive behavior. So all of this is very focused on all the things that autistic people supposedly cannot do or fail at or are abnormal at. So this is the medical model where it's kind of assumed that autistic people are inherently deficient in how they are. Now there's a new way of thinking about things, which is the neurodiversity model, where we assume that instead of a deficient brain, people just have different brains. And there might be a disability there, but at least part of the disability might be social. And what that means to have a social disability is that you can't do things because it is your social environment that disables you and makes it impossible. So for example, let's say I have ADHD and my sleep rhythm is that I cannot fall asleep early. I only fall asleep very late in the night, and that means I will sleep late in the morning. Now, that might make it very hard to keep a job down if there are no flexible work hours or to go to school regularly. But that is because there is no accommodation for how my brain works. So it would be my environment that is disabling me, and it wouldn't be necessarily me who is deficient in that. So the strengths and challenges that a person are contextual. They are in the context of our society. And we often talk about spiky profiles now when we talk about neurodivergence. And that means that in non-neurodivergent people, they're kind of functioning. So, how well they do all the things that they're supposed to do. That level kind of is always the same. It might be a bit of a wave, but whether it's going to school or doing homework or cleaning the house, kind of the functioning level is relatively at the same level. Whereas in neurodivergent people, what we often see and experience is that some things we're super good at. Our functioning level is up here. And then other things we have really, really a hard time with, and we just cannot do it. So our profiles, our functioning profiles, are a bit more spiky. They go up and down. So this is a new way of thinking about neurodiversity. And another way is that in the past, we kind of thought about this spectrum as linear, going from less neurodivergent or mild neurodivergence or mild autism to very neurodivergent, severely autistic. So we have this kind of linear structure, and that is how we thought about things. So looking at someone like me, you would probably think Lisa is only mildly autistic, or her autism is very mild. Whereas if you see a little boy who might be extremely overwhelmed and rocking back and forth, you might call him severely autistic. But then there's another way of thinking about this. When you look at these kind of spider diagrams that are below this, right here, where we have all these different areas that a person can be good at or can have strengths and challenges. So on the right, in the right circle, we see that this person probably has a lot of problems with social situations. They might be overwhelming, they might not understand other people very well, but they might not have a lot of problems with their specific interests. And so this gives us a much more individualized view of each neurodivergent person, where they might need support and where their strengths lie. So when we ask whether autism, for example, is a disability or a difference or even a superpower, I would answer all of the above, none of the above, but they're definitely spiky profiles. And that it's very important to acknowledge individual strengths and challenges of each individual, that we acknowledge that there's just as much variance and difference between neurodivergent people than there is between non-neurodivergent people. There are non-neurodivergent people who are not very good at empathy, and there are highly empathic non-neurodivergent people, and that's the same for neurodivergent people. And then there's the topic of high functioning versus low functioning, which is also a very classic way of thinking about especially autism. And that is probably not a very helpful way of thinking about it, because if we classify a person as high functioning, we might miss all of the ways in which they might need support, and they might fall through the cracks. And at the end of the day, their well-being might be compromised because of that. Whereas if we categorize someone as low functioning, we might not see all the ways in which they might strive if they just had the right support, and all the strengths that they could show if they were only in the right environment. So again, this comes back to the spiky profile. We aren't just high functioning and just low functioning. Our profiles really go up and down. And there was a tweet about a year ago that I thought really kind of brought this home. So there was this neurodivergent person who tweeted that my spiky profile means I can easily give a complex lecture to 200 people, but I can't phone my doctor if I'm ill. And at the time, that really resonated with me because I was just preparing to give a lecture to an academic audience at an international conference, which I quite enjoy doing that. I don't really mind doing it. But the week before I had the flu, and my husband had to call the doctor for me because I can't make phone calls. So you see that this spiky profile can really be an important term to keep in mind when we think about neurodivergence. And then I quickly want to go through some myths that just might not be true about neurodivergent people. The first one is that autism is more common in males than females. And although this goes back to basically the beginnings of autism research, it was especially prominent or made prominent in the early 2000s by a professor called Simon Baron-Cohen, who said that there are two types of brains. There are male brains and there are female brains. And male brains are systematizing brains. So they're really good at math and they're really good at map reading and they have all this attention to detail. So this is a male brain. Female brains are really good at empathizing. They're really good at thinking about other people. They're really empathic. They talk about their emotions. And so because autistic people are more systematizing, and because systematizing brains are male brains, he called this the extreme male brain theory of autism. This theory has been criticized quite a lot. There's actually very, very little evidence, if any, for the fact that there might be a male-female difference in the brain other than maybe on a hormonal level. But it has really influenced everyone's thinking that autism is more common in males than females. So I have a question for you. What do you think? What is the male-female ratio of autism? So if there are 9 boys, is there one female that is autistic? And I'm talking about diagnoses, not actual cases. So how many people are actually autistic in males and females? Right, let's see. Oh yeah, very good. That's great. So most of you think there's no difference between male, female, if we want to buy into the gender binary, of course. And that is actually what recent research finds, is that when we take a large data set with a lot of people filling out screening questionnaires for autism, but we use diagnostic criteria that would also describe how non-males present as autistic. When we do that, we actually find that there is no gender difference in who is autistic. So most likely there is no difference. Another myth to forget is that ADHD is just an excuse for laziness and not getting stuff done. It certainly can feel like that when you have ADHD. I, for the longest time, thought that I'm really bad at life. Turned out I had ADHD. And to show you that this is not true, I want to kind of give you a list of all the things that people with ADHD deal with on a daily basis. We often struggle with emotional dysregulation, which means that the way our emotions come up can be quite unpredictable even for ourselves. So we might have a short fuse and kind of go into an ADHD rage if even a tiny little thing happens. We might have something called rejection-sensitive dysphoria, which means that we are very, very sensitive to any perceived kind of rejection, which can make us, really sad and feel horrible. On the other side, there's something called recognition-sensitive euphoria, which means that when we feel that we're recognized for who we are and what we've done, we can get really euphoric. Hobby graveyards is just a term that I really like because it describes that our interests can really jump from hobby to hobby, and you just might have little graveyards of all the hobbies that you've had in the past. A lot of us experience disordered eating because we have difficulty with accessing whether we're hungry or not. So oftentimes we forget to eat all through the day, and then we get super hungry at night because we haven't eaten all day. But because of our executive function difficulties, we might not be able to prepare a full meal, and so we just binge eat whatever is there. People with ADHD often have addictive behaviors or something called dopamining, where we're just looking for dopamine because that is what our brains are lacking, and oftentimes that might lead to addiction. I already mentioned this, but it can be really difficult for us to do our daily things. And oftentimes, because of the way our brain works, even a simple task like I want to unload the dishwasher can be quite difficult. So this is when a task chain comes in. So what often happens to me is I get up from the sofa, I go to unload the dishwasher, and on the way there, I see, for example, that one item that I haven't put away for weeks. So I take this item and I finally go and put it away in my bedroom. And then I suddenly see on the bedroom floor that there are so many things. So I start picking those up. And in that floor drop that is down there in my bedroom, I find something that I haven't seen for years. So I get stuck into this and I never get to actually unload the dishwasher. So because my brain just jumps from task to task, none of the million tasks that I start actually get done. And then we also have a lot of sensory differences. We are craving input on the one hand, so we easily get bored. I always, for example, have a fidget toy in my hand because I always need to be doing something with my hand. But on the other hand, we get easily overwhelmed. And so finding a balance between that can be really, really challenging. And again, it kind of goes back to the spiky profile, where we are kind of between extremes of how we function in the world. So taking all of this into account gives you an idea of what it is to have an ADHD brain, and that it's really not laziness or not being able to get stuff done. And then the last myth I want to talk about is that autistic people who are mostly men or have an extreme male brain, according to that theory I talked about earlier, do not have empathy. And I want to talk about a study, I think that is from 2015, where the researchers had two groups of people. They had autistic people and non-autistic people. And the first thing they did is they gave them a questionnaire that asks about how we think about other people, which is called the empathy quotient. So this is kind of a cognitive, higher level type of empathy that really tests whether someone shows empathy in the way that is expected by society. And it has been shown again and again that on this specific questionnaire, autistic people score lower than non-autistic people. In this study, however, they did a second thing, and they showed people the image, a specific image, which I will show you in a second, and I will give a little trigger warning. There is a knife in there, and it's not a very pleasant image to look at. And then they recorded people's bodily responses to seeing this specific image. So they put a little probe on their fingers, which measures how much a person is sweating in response to a specific thing they see or hear or feel. So this is the image that people saw, that they showed people. And then this is the bodily reaction of people to it. So the bigger graph here shows you that the autistic group actually had a much higher bodily reaction to seeing someone else in pain than the non-autistic group here. So on a bodily level, we are very, very empathic, and a lot of us also can show empathy. But the interesting thing about this paper is the title, which includes the words empathy deficit. So to me, what these researchers did was that they showed that autistic people have higher bodily empathy and lower cognitive empathy, and it's the other way around in non-autistic people, and yet they called it a deficit. And I think this is a really good example of how research can be biased in itself, and kind of believe things that are not necessarily in the data that they find. So this is, it can be quite a harmful myth that autistic people do not feel empathy. And in response to that, an autistic researcher called Damien Milton started doing research on this. And what he found is that actually there is something called the double empathy problem. It's not just that autistic people have difficulty sometimes understanding non-autistic people. It also goes the other way around. Research keeps showing us again and again that non-autistic people are also not very good at understanding autistic people. So while autistic people understand autistic people really well, and non-autistic people understand non-autistic people really well, there is a problem in between, but the problem is on both sides. If there is a deficit, it's not just the autistic person, which I think is an important thing to keep in mind. Okay, I will now talk to you about neurodivergent well-being, or rather, why it is so low well-being in neurodivergent people. So what research has shown over the past decades, time and time again, is that on the one hand, in autistic people, we find higher rates of depression, of anxiety, of self-harm, of suicide, of chronic pain, of chronic fatigue, of a lot of other chronic physical health conditions, that we have 16 to 30 years less life expectancy, that we are more likely to experience trauma, that we are more likely to be bullied. But on the other hand, we also have less access to medical care, to tailored treatments, to accommodations at school and at work, to accommodations in social settings. There's less understanding for us and how we feel in society. There are a lot of stigma and stereotypes. And you can really see how this creates kind of a lot of pain in people, that the rates are already higher, we're already more vulnerable to things, and then all the things that could help are also not available to us. And there is fantastic research at BSMS by my colleagues Mary Doherty and Seb Shaw, which did a very big mixed method study with autistic adults, and they asked about barriers to going to the doctor for autistic people. And you can see here in this figure, the green bar are the autistic answers, and the yellow ones are the non-autistic ones, that approximately 70% of autistic people had an untreated mental health condition that they couldn't go to the doctor with. Around over 60% had untreated physical health conditions. And then what is really shocking is that life-threatening conditions, around 30%, were untreated for those. And they also asked these people some questions so they could write down what they thought, and I will just share 2 quotes with you. One person said that they did not seek advice for chest pain because of anxiety about the process of seeking help. And one person said, I feel so disrespected by healthcare professionals that I'd rather suffer at home than set myself up for ridicule. And the more we looked, or my colleagues looked into this data, the more they found that there are so many barriers to autistic people going to the doctor because they're often not believed, or they can't deal with the sensory nature of a very busy waiting room. They have difficulty describing their pain or what is wrong with them in a way that healthcare professionals are able to understand. And apparently healthcare professionals are not trained enough to care for autistic people. So there seems to be this really, really big burden on neurodivergent people health-wise that unfortunately is also created because the healthcare systems kind of aren't set up for us either. Now I want to talk with you about loneliness in autistic adults. And before I go into this, I want to ask you a couple of questions. And I think each of these questions is timed for 15 seconds. So it's a bit of a quiz. And here's the first question. True or false? Loneliness is 4 times higher in autistic than non-autistic adults. You may cast your votes. Nice. 94% of you were right about that. That is true, in fact. Okay, Next one, true or false, autistic people are not bothered by loneliness. Very nice, 97% say it's false, and that is true, as I will show in a minute. And last one, there is a scientific theory that says autistic people are not motivated to have meaningful social relationships. True or false? Ooh, that's interesting. Almost 50-50. Okay. In what follows now, I will tell you that this is indeed correct. There is such a theory. I will talk about it in a minute. Olivia is our winner. Congratulations, Olivia. Well done. Okay, so I will talk with you about our research on loneliness in autistic adults. And the motivation for us to do so is that there is the stereotype, and actually a scientific theory, that says that autism can be construed as an extreme case of diminished social motivation. So it says that autistic people are not motivated to seek meaningful social contact. On the other hand, we find that loneliness is 4 times higher in autistic than non-autistic adults. That is from the National Autistic Society, who did a survey in 2018. And we know that loneliness itself is really, really bad. People who feel lonely quite a lot have increased cases of all sorts of cardiovascular disease and diabetes, cancer, and they also die earlier. So what we wanted to know is, do autistic people choose to be alone and they're not distressed by loneliness? Or are they in fact distressed by loneliness and have just as much negative consequences as non-autistic people? So we had 109 autistic adults and 100 non-autistic adults, and we compared these 2 groups, and we gave them different questionnaires. They were the UCLA Loneliness Scale, which is a very prominent questionnaire about loneliness that is used quite a lot. And then we also added some questions to that. So after each of the questions that was already in the questionnaire, we asked them, how much does this upset you? So how often do you feel that you lack companionship? And someone says, I always feel like that. And then if we believe the theory that autistic people aren't upset by that, they would then answer not at all. Or if they are really upset by loneliness, they would say extremely. So we wanted to see if we compare these 2 measures, the loneliness itself and being distressed by loneliness, do we see a similar pattern in autistic people and non-autistic people? And then we also had a qualitative study where a colleague of mine asked autistic people about their experiences with loneliness. And here's what we found. The first thing we found is that if we just give them the normal questionnaire, loneliness is much higher in autistic people. You see that here on the left. These are all the individual data points. And you can see that on average, their score is higher than the non-autistic group, but also all of the individual scores are higher in the autistic group. We found the same pattern for the distress measures. Some autistic people obviously are not very distressed by it, but it goes much higher than in the non-autistic group, and the mean is also much higher. So we find that there is more loneliness in autistic people and that they are indeed distressed by being lonely. And we also see that in this graph here. So what you see is these points are where people scored on loneliness and how distressed they are. And you kind of see the same pattern in both the autistic and the non-autistic group. And then I wanted to read you a quote from one of our participants in the interview study. who said that I'm trying to reach out, I'm trying to find my people, but it's not, as you say, it's not connecting deeply within me. It all still feels a bit hopeless and superficial. And I think, again, this quote really expresses that this autistic person is trying to reach out and they do want to find their people, but it is really difficult. So with this study, we showed scientifically that autistic people do want social connections and that they are distressed by loneliness, and that this stereotype, again, is false. Okay, so for the last 10 minutes, I now want to, after talking so much about brains and what people think, and about, kind of higher level things, I want to go down to the body. So neurodivergence from the neck down, and what joints have to do with it all. And that might seem a bit odd in the beginning, but hopefully I can make sense about it for you. Okay, there's such a thing as joint hypermobility. Some of us have really, really bendy joints. If you look on the left here, if you can do some of these things, or if you, for example, sit like this, or you have a hand that kind of goes like this, or a thumb that kind of goes like this, you might also have joint hypermobility. And for some people, that's really good. Some musicians kind of really need bendy, long fingers for their guitar or piano play. Or some swimmers and gymnasts might really benefit from having hypermobile joints. But as you will see in a second, it is also connected with a lot of chronic pain issues and chronic fatigue issues and other physical health things. But before I tell you about all of this, I want to know what your score is on a screening questionnaire for joint hypermobility. So if you look at this here, count how many times you say yes. So the first question, and you have to go on Slido for that. Can you now, or could you ever place your hands on the floor without bending your knees? Can you now, or could you ever bend your thumb to touch your forearm? And the way you do that is you kind of hold your hand like this, and you try and put your thumb against your forearm. Please don't hurt yourself. If it doesn't work, don't do it. As a child, did you amuse your friends by contorting your body into strange shapes, or could you do the splits? As a child or teenager, did your shoulder or kneecap dislocate on more than one occasion? And do you consider yourself double jointed, which means hypermobile? Okay, now let's see. How many of you scored 0 or 1? Seems to be the majority so far. Or 2 or higher, 36%, 38%. So this is the screening questionnaire we often use to see if people have joint hypermobility or not. And if you have a score 2 or higher, this is a pretty good indication that you do have joint hypermobility. Now, a very interesting fact, at least to me, and I hope to you too, is that when we look at groups of neurodivergent people and non-neurodivergent people, and we give them this questionnaire or others that test for joint hypermobility, we find something like this. The comparison group of non-neurodivergent people is about 20% of them are hypermobile. Now, when we look at the groups of ADHD, autism, and Tourette syndrome, this goes up to almost 60%. And this is something that research time and time finds, is that neurodivergent people are, our most recent data says, 10 times more likely to have joint hypermobility than non-neurodivergent people. So this is part of what I do in my research. And one thing we found is that if we take neurodivergence out of the picture and we look at a big data set, and we look at people who are 18 years old, we find that those who have joint hypermobility are much more likely to also have depression and anxiety. So you can see here that people who have joint hypermobility are approximately 4 to 5 times more likely to experience depression and anxiety at age 18. We also find in our research that neurodivergent people are more likely to experience symptoms that are often connected with joint hypermobility, such as musculoskeletal pain, or something called orthostatic intolerance. So for example, getting up very quickly and becoming dizzy or fainting, that would be orthostatic intolerance. And again, we see that the neurodivergent people experience this a lot more than non-neurodivergent people. So when we look at this relationship here, neurodivergent people experience these symptoms of pain and of orthostatic intolerance more often. When we look at this in a specific way, statistically, this relationship here is what I just showed you. Neurodivergent people experience these symptoms much more often. And what we find is that hypermobility is likely one of the factors that explains this. So neurodivergent people who are hypermobile are more likely to experience symptoms of pain and of orthostatic intolerance. And now, of course, the big question is, why is that the case? The answer is, we're not quite sure yet, but we have some thoughts about it, of how this could all be. And for that, we have to understand that joint hypermobility really is a symptom of something much bigger. It is a symptom of having connective tissue disorders. And your connective tissue is really everywhere in your body. It makes up your skin. It connects your muscle to bones. It holds your joints in place. It holds your organs in place. It even covers your nerves in your central and autonomic, so fight or flight nervous system. And when we keep that in mind, that connective tissue is everywhere, and when there is a difference in connective tissue, and it is too loose, and it makes your joints hypermobile, then it probably also has other effects because it is everywhere in your body, and so much of your body is different. And holding it all together is a bit more difficult. So what we actually see in people with connective tissue disorders is that they have a lot of unusual skin or allergy type symptoms. We often have very stretchy skin or very smooth velvety skin. A lot of people with joint hypermobility look quite young or younger than they actually are. We might have a lot of unusual allergies. We have increased musculoskeletal pain if we have joint hypermobility and arthritis. We might have a lot of joint dislocations or clicky joints or joint pain, even when we're quite young. We might have irritable bowel syndrome or food sensitivities or other weird kind of gut issues that don't really have an origin that we can point to, and this is the reason. And we might experience quite a lot of brain fog and dizziness on standing, so something like postural orthostatic tachycardia syndrome, and we might experience a lot of fatigue and anxiety. So in our lab, we often advocate that all services that screen all people of all ages for autism and ADHD should also screen for joint hypermobility, because we know that there are so many of us who are neurodivergent who also have joint hypermobility. And it might just be one of the big reasons why our well-being is so low, because it has so many effects, or can have so many effects on how we feel, our emotions, but also our bodily well-being. But if we don't know that this is what's happening, we also can't do anything about it. So knowing what the problem is, where the pain comes from, where the sleepiness comes from, is really the first step, and then we can find ways to make it better. And speaking about how we can do better, this is the last few slides. There are really good things that are happening for neurodivergent people. I know it was a lot of kind of doom and negative things that I've talked about, but there are good things happening. My colleagues, Dr. Doherty and Dr. Shaw, have, for example, come up with this autistic space framework that is already widely adapted in the UK and in a lot of NHS services, where they ask that we think about sensory, predictability, acceptance, communication, and empathy when we deal with autistic people in healthcare services. And they also give some advice on what that might mean or what that could look like. So we might want to consider what the sensory environment is in your hospital. You might want to consider how you communicate with people. Make sure that you know that empathy kind of goes in both directions. And I think that this framework should and could be applied in many other settings and make life for autistic people easier. As you probably know, there's lots of good stuff on the internet as well. One of my favorite content creators is someone called Neurowild. You find them on Facebook and Instagram. They make really, really nice comics and that show how we can do better, especially for neurodivergent kids. And I find these just heartwarming and really nice to see because they just explain everything so well. And I think it's great to see neurodivergent content creators out there educating people and raising awareness. And lastly, this is a graph from research with one of my medical students. And what this shows you is we looked at how many papers or how many academic publications there were on what positively contributes to well-being in autistic people over the years. And you see that there is really a lot. It's going up quite a lot. The reason it's so low for 2013 is because that's in January 2023, not 13, sorry. That's when we stopped our search. So we only had 1 month for 2023. But you see that a lot of people are more and more interested in how we can make it better for autistic people. My very last slide is just a little extra info I want to send you home with, and that is that there is actually now evidence that joint hypermobility also exists in dogs, and it is, like in humans, connected to anxiety and reactivity in dogs. You can see here Taco Bella, she's my little Chihuahua dog, and I'm pretty sure she is hypermobile as well. Okay, I now look forward to your questions. If you were so kind, I would ask you to share what you have learned today. Your answers should not show up. I'm pretty sure that I put that as a setting, but it would really interest me, and I would really like to hear what you have learned today so that I know that what I wanted to teach you really came across, or maybe not, and I have to change something in the future. So I really appreciate that. And with that, I open the floor for questions.
Excellent. Thank you so much, Lisa. Yes, if folks want to carry on popping in their responses to that on the Slido, that's fine. If you do have any questions for Lisa, please pop them in the Q&A. We'll try and get through as many of them as possible. We've got about 7 minutes, so we'll sort of do a very, very, very speedy Q&A. But we've had a few come in over the course of the lecture, so we'll start with those. So we've got some good ones that have come in already. So here's a good one. Where's the line between being neurodivergent and just being neurotypical with some different traits, if that makes sense?
That does make sense. It's a question that I have asked myself a lot, so it's a really good one. And I think the honest answer is I don't know. And it is such a good question because it's really, I think we really are not in a good place as a society to answer it. Because the question is also who are we to make diagnoses about people, and kind of putting them into these categories. So I am not sure when it tips over into neurodivergence and when it's just a lot of traits. The way it works now at the moment is that you can only get a diagnosis if your neurodivergent traits cause you problems in life, which often is the case. So according to that system, if you don't have any problems with these things that you see as in yourself, you wouldn't be neurodivergent. I don't know if that really mirrors reality. And yeah, I think I will stop talking now because, like I said, the honest answer is I don't know. But it's a good question, and I wish I
No,
knew.
that's very fair. That's very fair. We've got some other really good ones. We've got some about the sort of physical traits, which is quite interesting. So, wouldn't this loose connective tissue also be a main contribution to hypersensitivity to sound? So ear organs can vibrate more easily.
Oh,
We've
that's
got
so great. Yes, exactly.
yeah, and there's another one that says, do you think there'll be more physical problems associated with neurodivergency as well?
Yes, yes, that's what we find. And that is exactly what I want to focus my research on in the coming years, is this connection between sensory sensitivities and connective tissue, because I think you're right. There are so many ways that we don't even know yet how this might impact us. It might also be that your retina is made differently, or some nerve somewhere is just made differently or covered with some different type of connective tissue that influences us in ways we just don't know. But we do know that it does cause a lot of physical problems, and especially those that when you take them to the doctor, they're often like, your tests are normal, can't do anything for you. That is actually what we find most often, is that there are a lot of physical symptoms, but doctors often don't know about connective tissue disorders, and therefore people take a long time to get help.
Yes, that makes a lot of sense. We've got another little follow-up one for this. Are you more likely to be hypermobile if you are neurodivergent, or the other way around?
It's a really good question. We find both. We find it goes in both directions. We haven't published on it yet, but we will soon. It does go in both directions.
Another good one about the sort of physical characteristics. Are there physical brain changes that you can see on scans if you are neurodivergent?
So then for the neurodivergent, it's a really interesting question, especially for me because I teach in second year in the neuroscience module for medical students on autism and ADHD. And I always keep thinking, the more I look at the research, the more I think neuroscience doesn't really know what is going on in autistic and ADHD brains, because we keep finding differences, but then we keep not really finding them. And then all of the areas are a little bit different. We find structural differences, so in how your brain is built, especially in the memory center, the hippocampus. For ADHD, we find it more on a chemical level with dopamine. We find it sometimes in emotional centers, so amygdala and insula in the brain, especially for autism, where anxiety is really high. So there are brain differences, but what exactly they are and what they mean, we're not quite sure. I don't think we're quite sure.
Excellent. A really good one, and one that's very pertinent. How do you think healthcare should be changed for neurodivergent people?
That's a really good question. I think we have to start with training doctors to recognize who might be neurodivergent and to create awareness of how that might have to change our behavior when we are doctors or other healthcare professionals, to make these people more, or to make us more comfortable in a situation. We might have to ask different questions. We might have to take into account that we often take things very literally. I'm 37 years old, I only recently realized that when my dentist asks me if it's still doable, he actually is asking, do you need more pain relief? I didn't put that together because I'm so literal. I didn't know that because it's still doable, yeah, I can still sit here and take the pain. What does that mean for it to be doable? He actually asked, do you need more pain relief? And now I know that I have to say yes to this question. But so that there are just many different ways that if people are aware of how things might be understood and how we might have to communicate, and they could change their ways, then that would really benefit autistic people and other neurodivergent people.
Yes, definitely. Yes. So I think this might have to be our final question. There's lots of really great questions, and I wish we could answer them all. But I think this is a good one to finish on. As I hope it will help. And it's just simply, how is autism diagnosed?
Yeah, that is a good question. So here in the UK, it is different for whether you are over or under 18. If you are under 18, I'm honestly not entirely sure because my research is focused on adults, but it's definitely done through CAMS. If you are an adult, you have to go to your GP and they have to refer you to a specialist service, where you probably are on a very long waiting list, unfortunately. And then you go to a specialist service and you fill out a couple of questionnaires beforehand. And then you talk with a professional about your experiences and how you filled out the questionnaire. They then talk with other people in the service about your case and decide what the diagnosis should be. There are also private services, and there is something called Right to Choose, where you might be able to access through the NHS professional NHS private services without paying for them.
Excellent. Thank you very much, Lisa, and thank you for your talk this evening. It's been really interesting, and I've certainly learned a lot as well, which is fantastic. And I know from the response that we've had on the Q&A and chat that it's been much appreciated. Thank you again to Dr. Lisa Quadt for your lecture this evening. It's been fantastic. Thank all you attendees for coming along, and we do hope to see you at another lecture in the future. Thanks very much, folks. You can now exit the webinar.
Thanks, everyone.